Now let's move on and talk about RV failure, differential diagnosis, and diagnosis. Now, we're going to take a framework that you guys are already familiar with, the pump, tank, pipes framework, because that's a framework that you guys are accustomed to using to think about shock. So rather than coming up with an entirely new one, we're going to just sort of reframe it and reapply it to allow us to think about RV failure and pulmonary hypertension as opposed to regular LV failure. So, the way we're going to translate this is 3 categories, and these are our 3 differential diagnosis categories for why your right ventricle might be failing. 1, pressure overload. That is your pipes problem. 2, volume overload. That's your tank problem. And 3, decreased contractility. That is your pump problem. So if you have a pressure-loaded RV, if you have a pipes problem, that means that basically your pipes are clogged. They're clogged, the pressures are high, and what's happening is the RV can't push against them. The RV itself might be okay, but it's dealing with too much afterload. That's our pressure afterload. Then you can have volume overload. That's your tank problem. That is when your right ventricle has too much volume to handle. It's overloaded and it can't keep up with all the volume that's being presented to it. And finally, decreased contractility. This is your pump problem. This is when your RV can't push anything forward because its contractile function, its pump function, is something wrong with it. It's broken. So, pressure overload, volume overload, and decreased contractility are 3 categories when we're thinking about the causes of RV failure. Now, what are the etiologies of these 3 categories? So pressure overload, one of them is your just primary pulmonary hypertension patients. These are the patients who it's like they have regular hypertension, but instead it affects the pulmonary vessels. So our primary pulmonary hypertension patients. These are also our acute thromboembolism patients. Now these patients both have a mechanical problem, that we have that, big Goomba in their lungs that's mechanically obstructing the RV from pushing blood forward, but thromboembolism also causes inflammation in the pulmonary circulation, and inflammation in the pulmonary circulation causes vasoconstriction. So they also get pressure overload. And finally, lung disease. So this is all of our lung diseases where your poor right ventricle is trying to push blood basically through a brick, pressure overload. What about volume overload? So what are the causes of volume overload? Well, one is just insufficient diuresis. If you have a patient that has baseline pulmonary artery or right heart disease, and you just get them overloaded, they're insufficiently diuresed, maybe they went into renal failure, that can be one thing. But another thing is iatrogenic. This is us. If you give anybody enough volume, massive amounts of volume, you can start causing problems with the right ventricle. And finally, decreased contractility. What are the causes? Well, one is myocardial ischemia. We all know that one. You have an RV heart attack. 2, myocarditis. Now, it's quite rare to see RV failure in isolation in myocarditis. It happens, but it's quite rare. But the other one is sepsis. As we talked about, sepsis-induced cardiomyopathy can have a big effect on the right ventricle. And that effect has a mortality difference. Now, I actually personally think that part of that is because we sort of often tend to administer a lot of fluid to septic patients, and now we're administering a lot of fluid to an RV that may already be hurting. So I think that's actually probably multifactorial. But let's explore these a little bit more one by one. And let's start with pressure overload. So this is this problem here, right? This is the problem that the RV just cannot handle high afterloads, and that afterload is a primary determinant of normal RV function. The RV starts failing very rapidly when it is pressure overloaded. But there's something else that's happening here, because pressure overload starts causing you other problems. Why? Well, remember that the RV is normally perfused during both systole and diastole, but that perfusion relies on a perfusion pressure gradient. And that gradient relies on the fact that RV systolic pressures aren't that high. But if all of a sudden we increase the RV systolic pressures, let's say from 20 to 60, all of a sudden we are losing a lot of perfusion. And so that is a secondary effect of pressure overload. Now let's take a minute and talk a little bit about volume overload. Because one of the best ways to get my head to explode is for somebody to tell me that the right ventricle is in fact, quote, preload dependent. It drives me crazy, because this is really where we get our physiology epic fail. this reasoning right here, what we've all been taught about fluids and RV failure. So why have we been taught incorrectly about this? Well, there's actually a very good reason for it, which is that if we're talking about decreased contractility, fluids is sometimes the right thing to do. But we have to ask ourselves, why? Why is it that for a right ventricular infarct, like let's say you infarct your right ventricle and, the right ventricular contractility is down, in that case, fluids are the right thing to do, at least initially. But that's not the same situation as, let's say, a massive PE. Why? Why is it? Why is an RV infarct different than a massive PE? Why is it correct to give fluids in an RV infarct, but a terrible idea to do it in a massive PE? Well, it's because of the afterload. If you have an RV infarct, is your afterload high? No, it's not, right? Having ischemia to your right ventricle, if that's your primary thing, your RCA got obstructed, that doesn't do anything to your afterload, but a massive PE does. And so if the primary problem is that the pipe is blocked, giving more fluid is not going to get you anywhere. Now, if you are more comfortable with medicine than plumbing, let me give you another analogy. Let's say we have this patient. We take a look at their x-ray and yeah, that kind of looks like a bowel obstruction. Again, not a mystery diagnosis. If you have this patient, let's all answer together a multiple choice question. You see this patient in the ED. What is the next best step in management? Is it A steak dinner, B, give them a large milkshake, C, feed them 1 dozen hot dogs, or D, put a nasogastric tube in? Obviously, we're all going to go with D, right? Because when somebody has a bowel obstruction, our solution is not to say, I know what I'll do. I'll just push everything through by giving them a bunch of hot dogs and that'll push everything through. No, we don't do that. Why? Because when the pipe is blocked, giving more hot dogs, or in the case of the right ventricle fluid, doesn't unblock your pipe. It just causes your sink to overflow, or in the case of this patient, your patient to vomit. So this idea of preload dependence, it really depends itself on what is the afterload. Now, that being said, when you have a patient whose RV contractility is down, it's then kind of a reasonable thing to do to be like, okay, well, the RV is unable to push fluid forward on its own, so I'm just going to give it some extra fluid since the afterload's okay. If the afterload's okay, sure, I'll just give some extra fluid and use that fluid to sort of create a pressure gradient to push things forward. And that works for a while, but only to a point, because there's another important piece about this physiology. So take a minute, and I want you to imagine in your head the parasternal short view on echo, and it looks something like this. Now, on a normal day, the LV is a lot bigger than the RV, and the septum bows into the RV. Why? Because the pressures in the LV are higher. But there's a thing that happens during diastole, and I call it a diastolic filling competition, because keep in mind that the RV and the LV, they're living in the same space. They live in the same house. They're encircled by the pericardium, which is not an elastic structure. So the more one fills during diastole, the less the other one does. So what that functionally means is that if you start giving fluid and you give some and it's going well, but then you get a little overzealous and you give so much fluid, in fact, that the RV can't handle it anymore, what then happens is the RV can't push the fluid forward. And when the RV can't push the fluid forward, it starts backing up. And when it starts backing up, now the left ventricle starts losing that diastolic filling competition. Why? Because they live in the same house. And now the right ventricle is smushing down on the left ventricle and preventing the left ventricle from being a big, good, nice receptacle for preload. So there's this paradoxical thing that happens, which is that delivering too much fluid to the right ventricle can actually decrease left ventricular preload. Now, this happens very early on in patients who already have high afterload that the RV is pushing against. But if you massively flood somebody with fluid to the point the RV can't keep up with it and it starts blowing up, it's going to start mashing down on the left ventricle, and the very thing you were doing to increase preload can paradoxically decrease it. Now let's take a minute and talk about recognizing RV failure, because honestly, I feel like a lot of the time, this is half the battle, is that we're not looking for it and it can be hard to recognize. And one of the reasons it can be hard to recognize is that it's really easy to misinterpret common labs and tests that we get. So for example, lactate. we have this idea that lactate somehow magically means sepsis. Lactate doesn't mean sepsis. Lactate can indicate all kinds of things. It can indicate physiologic stress. It can indicate hypoperfusion. It can indicate that your patient's in shock. But just because they're in shock, you don't know why they're in shock. And if they're in cardiogenic shock from RV failure, they can have a high lactate. Similarly, BNP, it can mean left ventricular failure, but it can also mean a right ventricular failure. LFTs, liver function tests, this is a big one. So keep in mind that the right ventricle, it's going to back up into the abdomen, not into the chest. And when that happens, things get a little confusing for us. So for example, we have this idea that if you have heart failure, you're going to have this big, wet, juicy chest x-ray. And that's true in left heart failure, but in right heart failure, not so much. Because again, the left ventricle backs up into the lungs, right? You're going to get that pulmonary edema, but the right ventricle doesn't. The right ventricle is before the lungs. So the right ventricle is not going to back up into the lungs. The right ventricle is going to back up into the abdomen. So these patients, in the same way that a left heart failure patient will present with pulmonary edema, these patients can often present with abdominal pain, abdominal distension, because think about it like the pulmonary edema of the right heart, because that's where it backs up. Now, it can be really, especially to figure this out, acute RV failure in chronic lung disease. Because the thing is, often this ends up being this chicken egg thing. When you have somebody and they're coming in and let's say they have interstitial lung disease and they don't look good, and let's say that they're tachypnic and they're hypoxemic. Well, why? Is it that they're tachypnic and they're hypoxemic because they're having an exacerbation of their interstitial lung disease or maybe an exacerbation of their COPD? Or is it that maybe they're having an exacerbation of their pulmonary hypertension? And their tachypnea is because that's what people do when they're going into shock. And their hypoxemia, take a look at that waveform. Are they truly hypoxemic? Or is it a poor waveform and they're just not perfusing? And it can be really difficult to parse this out because often what happens is that they start out maybe with a minor exacerbation, let's say a little pneumonia on top of COPD. Well, then they start getting a little hypoxemic, little hypercarbic that causes elevated right-sided pressures and maybe tips them over into RV failure. So it can be really hard to parse this out. And if I don't know, I treat both. But I'm very careful about intubating these patients who have both acute RV failure and chronic lung disease and really try and spend some time very early on trying to parse out, yeah, I'm going to treat your RV failure and your lung disease. But intubation, as we'll talk about later, it can be very scary in these patients. So it is worthwhile to try and figure out where am I in my chicken egg process here. Now, ultrasound. Ultrasound can also be very deceptive here, because you can see some things on ultrasound that cause you to be a little confused. And the main thing is a hyperdynamic left ventricle. So we do this all the time. Let's say a patient comes in, they're a little hypotensive, we give them a liter of fluid, they don't get better. We as responsible doctors, we go reassess and often we'll ultrasound them. And we'll ultrasound them and be like, look, the LV looks great. My left ventricle squeeze, it looks good. I guess that means that, I can give them some more fluid because their left ventricle is really squeezy. It looks great. Here's the thing. Just because your left ventricle looks hyperdynamic, looks underfilled, you don't know why it's underfilled. It could be underfilled because the patient's truly hypervolemic, but remember, the only way the left ventricle can get fluid is for the right ventricle to deliver it. And if the right ventricle is not delivering, your left ventricle is going to look really hyperdynamic and really underfilled, and it is, but it's not because the patient's hypovolemic, it's because the right ventricle is not giving it anything to work with. Another thing that you will see is that in these patients, a lot of the time, what you'll see is their IVC is distended. And so if I see a patient who has a hyperdynamic left ventricle with a really distended IVC because my right ventricle is not pushing that fluid forward, that's something that gives me a clue. Now, you could ask, why can't I just assess the right ventricle directly? Well, ultrasound's tricky. If you're trying to assess systolic function of the right ventricle, it's actually not that easy. Because of the way that the right ventricle contracts, you can't really just eyeball systolic function of the right ventricle in the same way you can of the left ventricle. So I often won't really try to do that because we're not that good at it. Same thing with RV size. In late stages, if the RV is completely blown out, it can look dilated. But often, early, especially in patients who have chronic pulmonary hypertension, who have a big, what I like to call, or what actually one of my favorite attendings in fellowship like to call, an Olympic trained RV. It's big, it's muscular, it's thick. Often their right ventricle's big, but not that big, not completely dilated. So that can also be deceptive. What I like to look for, and to me, because I'm not a fantastic ultrasonographer, and so, I can't always get some more fancy measures and try and really figure out, oh, is my RV contractility okay? I find one of the most useful things I look for is actually septal flattening. Because this tells me a couple things. One, it's a relatively easy view to get. It's an easy thing to sort of eyeball. Do I have septal flattening? You just need to make sure that in this parasternal short view, your angle of insonation is okay. But I also like it because it tells me something useful about physiology, because it can help me distinguish between pressure overload plus minus volume overload. Because here's the idea. If I have a pressure overloaded right ventricle, then my septal flattening is going to occur in both systole and diastole. But if my right ventricle is just purely volume overloaded, then I'm just going to see it in diastole because the systolic pressures aren't going to be high because, the RV is not pushing against high systolic pressures. It's just volume overloaded, and you're going to see that in diastole. So that's something I'll also look for. Now, lastly, for the sort of more intensivist crowd out there, let's talk a moment about swans. Now, we're not going to put swans in people in the ED pretty much ever, nor should we. But in the ICU, I do find having a swan in these patients sometimes can be very useful. I find it useful because I can then really know what their true pulmonary pressures are because, echo and a pulmonary pressures measured on echo can be deceptive sometimes. But also, I just find it helpful. I found learning about the right ventricle with a swan very helpful. And so what I like to think about when I have a swan is the pulmonary artery pulsatility index. Because it can be tricky to interpret these numbers. Because if I put a swan in and my PA pressures are 75/40, what does that mean? Should I freak out? I don't know. Well, I like to use this number because it really gives me a good sense of what's actually happening, not just with my pulmonary pressures, but how's my RV handling it. So you calculate the pulmonary artery pulsatility index by your PA systolic minus your PA diastolic, so your PA pulse pressure, divided by your CVP. And the number you're looking for is greater than 1, more or less. But basically, the lower that number is bad, the higher it is good. If it's greater than 1, I'm feeling relatively okay about this. The less than 1 it gets, the less good I'm feeling about this. So let's talk about what this means. Because why this number? Where did we come up with this? So let's take our right ventricle and our pulmonary artery. Let's say, for example, on a normal day, we have PA pressures of, let's just say, 25/10. That gives us a pulse pressure of 15, right? So 25 minus 10. So that's the pulse pressure, that's the pulsatility that the RV is generating to push against these PA pressures. Now, the RV is being handed some amount of pressure. That's the CVP. So during every beat, the RV gets handed some amount of pressure with the CVP, then pushes that forward against the PA pressures. And so really the question is, can the right ventricle push as much pressure forward as it's being delivered every beat? And that is the PAPI of 1. So in this case, we'll say the PA pulse pressure, 25 minus 10, divided by the CVP of 5, that's a PAPI of 3. That's good. Your right ventricle's doing great, because what we're saying is that the right ventricle in this case can push as much pressure forward as it's being delivered. It can push at least that much forward. Because when it can't, that's when things start backing up. That's when we get in trouble. Now let's take another example. Let's say you have a patient, they have chronic pulmonary hypertension. You put in a swan and everybody loses it because their PA pressure is 75/30. Am I worried about this patient? Is this a huge problem? Should everybody panic? I don't know. I mean, in the long term, yes, but right this second, it depends what their CVP is. Let's say their CVP is 15. Let's calculate a PAPI. So 75 minus 30 divided by 15. Well, that PAPI is also 3. It's good because even though these pressures are high in the pulmonary artery, this RV, it's Olympic trains. It can handle it. It's pushing at least as much pressure forward as it's being delivered. So that number looks scary, and is it a long-term problem? Yes, but in the short term, the RV's handling it just fine. What about these numbers? What if we have PA pressures of 35/25? Those numbers don't on the face look as scary as like 75 over 30. It's just, 35 over 25. But let's say we have 35 over 25 and our CVP is 15. Now let's do the math. 35 minus 25 divided by 15, that gives us a PAPI of 0.6. That's not so good because this is telling us that this patient probably doesn't have acute RV problems. It's telling us that even though the absolute values of those PA pressures are not that high, this RV is not handling it. So when I have a SWAN, I find this a very useful number to look at. And it sort of just helps tell me what is the significance, what's the meaning of those PA pressures, and bigger picture, because most of the time I don't have a SWAN. But this idea of can the RV move forward the pressure is being delivered, I find useful in general.